If you're listening to this podcast on YouTube, for a better experience, switch to the video version. The link is in the top right corner of the video and in the episode description. Hello and welcome, I'm Fernando, a GP in the UK. Today we're going to cover what to do when we encounter thrombocytopenia on a full blood count, always focusing on what is relevant in primary care only. I have based this episode on Haematological guidance by Camden CCG, Manchester Foundation Trust and King's Health Partners. The links to them are in the episode description. Right, let's jump into it. Thrombocytopenia is when the platelet count is low, which is defined as a platelet count below 150. But before we assume a true low platelet count, we need to remember that thrombocytopenia can often be an artifact. This happens when platelets clump together in the EDTA sample tube, giving a falsely low automated count. So, the first step is always to confirm the result with a repeat full blood count and a blood film. The blood film not only rules out platelet clumping, but can also provide important clues about the underlying cause. There are many potential causes of thrombocytopenia, so let's have a look at them. First, we have alcohol excess. Chronic alcohol use can directly suppress bone marrow production and shorten platelet lifespan. It is also frequently associated with chronic liver disease, where the spleen often becomes enlarged due to portal hypertension, destroying more platelets than usual, a process known as hypersplenism. Then we have recreational drugs, which can also impair platelet production or trigger immune-mediated destruction. Then travel history is also very important. Malaria, for example, often presents with thrombocytopenia, sometimes even before fever or parasitemia becomes obvious. Tuberculosis can also cause thrombocytopenia, either through bone marrow involvement or immune-mediated mechanisms. Then we should consider liver and renal disease. In chronic liver disease, we have already explained that hypersplenism is the most common cause of thrombocytopenia in liver disease. In renal disease, platelet lifespan is reduced because uremia makes platelets more fragile, causing them to break down more quickly. In addition, bone marrow suppression may also occur. Then we have medications as another common culprit. Non-steroidal anti-inflammatory drugs, heparin, digoxin, quinine, antiepileptics, antipsychotics, and proton pump inhibitors are all recognized causes. Most drug-induced thrombocytopenia is caused by either immune-mediated platelet destruction or by direct suppression of platelet production in the bone marrow. Heparin is the main exception because it causes thrombocytopenia through a unique immune reaction that activates platelets, leading to their consumption and a fall in the platelet count. Another possible cause are nutritional deficiencies, especially vitamin B12 and folate deficiency, which can impair bone marrow production and lead to thrombocytopenia, often alongside other cytopenias. We also need to consider viral causes. For example, Epstein-Barr virus frequently causes a temporary drop in platelets, which typically resolves within a few weeks. HIV and hepatitis B or C can cause persistent thrombocytopenia, either through direct bone marrow suppression, immune-mediated destruction, or associated splenomegaly. Then malignancy is also on the list, because both hematological cancers and solid tumors can infiltrate or suppress the bone marrow. Then we have bone marrow failure syndromes, such as aplastic anemia, which will often present with thrombocytopenia together with anemia and neutropenia. Another cause is immune thrombocytopenic purpura or ITP, which is an autoimmune condition that destroys platelets. In adults, ITP can be acute or chronic, and the platelet count can fall to very low levels even when the patient looks otherwise well. Finally, autoimmune conditions such as SLE can present with thrombocytopenia as part of a broader immunological process. Now that we have had a look at the causes, how should we manage these patients? We have already mentioned that we should confirm thrombocytopenia with a repeat full blood count and blood film. If the thrombocytopenia is confirmed, we will need to check if there are urgent criteria. First of all, we should arrange urgent same-day hospital assessment when the platelet count is below 20, and any concerning clinical features are present. These include active bleeding, even if minor, because bleeding risk rises sharply at very low platelet levels, an abnormal blood film, such as the presence of blasts suggesting acute leukemia or red cell fragments suggesting microangiopathic hemolysis, as these findings indicate potentially life-threatening conditions. And finally, an altered consciousness or confusion, which may point to serious systemic illness, intracranial bleeding, severe infection, or thrombotic microangiopathy. We should make an urgent outpatient hematology referral if the platelet count is below 50, even without symptoms. This is because at this level, the risk of spontaneous bleeding increases, and many underlying causes such as ITP, bone marrow failure, or hematological malignancy require urgent assessment. Additionally, when the platelet count is below 50, it is unsafe to continue antiplatelet agents or anticoagulants, so these should be stopped unless a specialist advises otherwise. We should also make an urgent outpatient hematology referral when the platelet count is between 50 and 100, and certain concerning features are present. These include splenomegaly, lymphadenopathy, other cytopenias, pregnancy or planned surgery. This is because all of these situations increase the risk of serious underlying disease or increase the risk of bleeding. However, if the platelet count is above 50 and none of the urgent referral criteria are present, we should then arrange the following baseline investigations. Firstly, we begin with a repeat full blood count and a blood film to confirm the thrombocytopenia, rule out platelet clumping, and look for abnormal cell morphology. Then we will check vitamin B12 and folate levels to rule out deficiency. Ferritin and iron studies are also helpful, given that iron deficiency can occasionally contribute to low platelets. Inflammatory markers such as ESR and CRP, which can suggest infection, inflammation, or an underlying autoimmune process. An autoimmune profile to exclude autoimmune-mediated platelet destruction. Renal, liver, and thyroid function tests to identify chronic liver disease, renal failure, and thyroid disease, given that both hypo and hyperthyroidism can contribute to thrombocytopenia. Then viral serology for HIV, hepatitis B and C, as these viruses can be associated with thrombocytopenia. And finally, we should perform any other investigations suggested by history or examination, for example, malaria testing after relevant travel, a TB workup, coagulation studies if there is bleeding, etc. After the initial baseline investigations, if no obvious cause is found, the platelet count is above 50, and none of the urgent referral criteria are present, we can repeat the full blood count after 4 to 6 weeks. If thrombocytopenia persists and remains unexplained, we should then refer the patient routinely to hematology. So that is it, a review of the assessment and management of thrombocytopenia. We have come to the end of this episode. Remember that this is not medical advice, but only my summary and my interpretation of the guidelines. You must always use your clinical judgment. Thank you for listening, and goodbye.